Okay, we will start LIVE2 now. The first case is a 35-year-old male patient, history of recurrent abdominal pain with several attacks of acute pancreatitis since 3 years. We did the IgG4, it was normal, and in the EUS it showed complete pancreatic divisome with no signs of chronic pancreatitis, no cystic lesion, and no tumor. In the MRCP, also it confirmed the results with the dorsal pancreatic duct measuring 3 millimeter. On October 2022, ERCP was done. We did opacification through the minor papilla, which confirmed the pancreatic divisome, but it was impossible to cannulate. So a pre-cut was done, as you will see in the video now. So a pre-cut was done. But also we failed to insert a plastic stent. So on 2023, he had multiple attacks of acute pancreatitis. Last MRCP showed the dilatation of the dorsal duct to 6 millimeter, as you will see in this video. So the plan is to do cannulation for the minor papilla and try to put a plastic stent inside the dorsal pancreatic duct with Dr. Horst Niehaus and Dr. Ammar Ghazali.
Hello, good morning. So I'm Horst Neuhaus from Düsseldorf. I'm for the first time here in Lebanon and first time in this unit, and it's a great pleasure to be here. I really enjoy the hospitality and also to work with this wonderful team. You have a great support, but a challenging case. So as you have already heard, this patient really suffers from repeated attacks of acute pancreatitis and most probably due to the pancreas divisum, and therefore the plan is to achieve sphincterotomy of the minor papilla, and as the MRCP showed, there may be a stenosis quite close to the minor papilla, and this is probably the reason that the previous cannulation failed. So I'm using the Fuji therapeutic duodenoscope, providing an excellent image, as we can see. And we see now here, this is the major papilla. And we are looking for the minor papilla. It's always above and usually a little bit more on the medial part. So at 1 or 2 o'clock above the minor papilla, above the major papilla. And now we can already see it at 1 o'clock. This is the area of the minor papilla. And in most of the cases, it's easier to access the minor papilla when we have the scope, as I do here, in a long root position, because we need to have a perpendicular access. And the direction of the Santorini duct is towards 10 o'clock. And so therefore we are in a good position and I prepared a straight catheter with a thin wire. So we have an 0.25 jack wire. And now the next step is to carefully evaluate the area of the minor papilla to identify the orifice. And this is quite challenging because the pre-cut was done, so the anatomy has a little bit changed. And now it's useful in these cases to inject secretine to stimulate the pancreas, but it's not available. It's even also very difficult to get it in Europe. It's very effective when you stimulate. So, and I suppose the area of the orifice is somewhere here, here in between, and I don't inject because with injection there's a high risk when you are not really in the duct that you create an edema, and then it's getting even more difficult. So therefore, guide wire cannulation first, as it's recommended for biliary cannulation. And now I ask to push the wire a little bit out. Okay, that's enough. So, and then I'm carefully probing here. Yeah, that's enough, okay. So I check if we can get it from here. As I said, I will insert it in the 10 o'clock position. This is maybe. So we will now. Now it's very difficult to see. Can you carefully advance the wire? No resistance, huh? Stop, the resistance. When we are in the duct, it should be smoothly pass. Okay, pull it back, please.
Hello. Dear colleague, if any question from the audience, please, anytime
So
you
I
can ask.
changed the angle a little bit. Try again. Resistance? Okay, then pull it back, yes. And carefully probing. Try to expose. Maybe the pre-cut was done here somewhere.
So can we ask a question, please?
Yeah, please.
Is there a special instrument used for ERCP for the pancreatic division? Such as the special guide wire, special...
Yes.
It's the
Yes.
standard.
I usually prefer a 018 Terumo wire. This is the most flexible, very thin wire, but this is not available. So a thin wire, of course you can also use an angulated wire, and you could also start with the sphincterotome, the mini-tome from Cook, for example, but here I would like to have a perpendicular approach to the minor papilla. So I think the pre-cut was done, pull the wire inside. So we re-evaluate if there is any other sign of an opening. Usually it's on top of the elevation, but the pre-cut maybe also insert push the wire a little bit out. You can also do it here.
Yes. Hello. Can I ask a question, please?
Yes. Please, go ahead.
Is EUS has a role here for this difficult case?
No, only if we fail, push the wire out. If we fail then we could use the rendezvous procedure with an integrate approach.
What's the caliber of the sphincterotome that you're
this is
using
not a
now?
sphincterotome. This is a tapered 4.5 French tapered catheter. So I'm try from here because I'm not sure. The pre-cut may have not been on the orifice. We continue and come back.
Hello, our second case for the LIVE2 is a 60-year-old female patient. The past surgical history is thyroidectomy and euthyrox. She has dysphagia and recurrent pneumonia. Upper GI series or barium swallow was done, and it showed a large diverticulum arising from the posterior wall of the distal pharynx near the nasopharyngeal junction located at C5, C6 level, suggestive of Zenger's diverticulum. So decision was made to do a Z-poem. This will be done by Dr. Moin Khashab and Dr. Jeffrey Van Bervelt.
So we have the septum here, and we have the esophageal lumen, and then the Zenker's diverticulum here. So we're gonna perform an endoscopic septotomy. Typically we do Zenker's Z-poem or Zenker's peroral endoscopic myotomy. I'm gonna demonstrate today a new technique called open Z-poem. So the idea here is to combine the advantages of Z-poem and a standard septotomy. So this advantage of a standard septotomy is that it gets rid of all the mucosa. So for large diverticula, you avoid the issue with redundant mucosa. The advantage of a Z-poem is we are accurate in delineating the distal part of the myotomy. So we do accurate myotomy and we don't leave any septum. So we'll walk through it slowly, but initially it's a standard Z-poem technique. So knife, needle out and inject. Stop, inject.
What's the expected time for this? More than Z-poem
Go ahead,
alone?
don't stop, don't stop. No. So because I call it open because we're not we're not gonna close at the end. We're gonna keep it open. Go ahead, inject. So we're not gonna use clips to close. So it actually is faster. Is that a little more?
What's the concentration of methylene blue here?
Just a couple of drops and the 10cc syringe. Stop, back, and let's get the SB knife. So we're gonna use a scissor type knife and see if we can do the entire procedure using the same knife. And we're gonna use EndoCut Q, and hopefully it works this time.
So you start at the top of the septum.
Yeah, we'll exactly. So in the past, we used to tunnel proximal to the septum. There's no need for that, so we just start over the septum. Just definitely makes the procedure much faster, easier. Open. So this is the scissor type knife here. So we're gonna just catch it and close. Close. And we're gonna use EndoCut Q current. Okay.
What's the name of this knife?
It's an SB knife, so it's a scissor type knife. And you may be familiar with the clutch knife, clutch cutter. It's very similar. Open. Yep. So rotate now.
So you always
Slow,
use
open and rotate. And rotate, yes. So rotate here with this. Okay? And sometimes there's a lag, so don't get frustrated. It will rotate just slowly. Continue slowly. Yep, continue. And stop.
You do the rotation. Yeah, absolutely. Sometimes it is difficult to use
Close.
when you are. There is another knife like this, the junior SB knife with a smaller jaw.
So that's, yeah, if you have like a small Zenker, and typically for ESD, this is the standard type, the 7mm larger one. So this is a large one. Open. Open. It's okay, good. And close. Okay, so now we're gonna go
inside.
just see where we are and start delineating anatomy here. So we see
Dr. Moin, please, what about the complications of post-procedure, please, according to your experience?
yeah, so this is, I mean, it's similar to a regular ZPOM, and the number one complication is leakage. And I say it is if you follow the principles that we're going to be demonstrating soon here, once we have better delineation of the anatomy, then the leakage rate is very low. And as I told you, we don't even close these days. I don't even put clips. And so here you're seeing the muscle. And I'm just trying to see if we can get any submucosal layer here to delineate anatomy. So here we see the muscle layer. It's very, very thick, actually. And here on this side, we see a little bit of submucosal layer. So I'm gonna continue to do what I'm doing now, and I'm gonna go a little bit on to get it more in the middle. So you see here, it's a little bit. We're very close to the. So if I go a little bit laterally, I think it will be easier. Open.
How do you determine the depth of CP myotomy for each patient?
Yes. So I'm hoping to demonstrate that once we get to the bottom. But this is definitely a very good question, and we'll be able to tell you. So about knowing where we are, how deep we are, and how long we can cut. So let's take this out. Give me a needle, please. But I should be able to demonstrate that shortly. Yeah, injection needle. You can do it both in terms of position on the back or left lateral. The left lateral can be just a little bit more comfortable with the scope position, so I choose it, but it doesn't matter. You can do it both ways. So here we're gonna just inject to get to see the submucosal layer better. And needle out, and inject, please. Yeah. Okay, stop.
You're on the anterior side now?
Yeah, this is on the esophageal side. Yes. Okay. Okay, you can give me the knife back now. And once we start with the myotomy, I'll be able to show you how exactly we can tell when we're at the bottom. So, so just bear with me. It's easier to show you rather than just tell you the theory behind it. So typically we don't tunnel with this knife, but I'm gonna just try to stick to one knife, see if we can do it. And so although the belief is that this knife is insulated, but it really isn't. So you see you can cut with the tip of it. And we don't have to create a long real tunnel here. This is just for delineation of anatomy and show you. So now we're on the tunnel side, on the tunnel on the esophageal side. We don't have to create a complete tunnel, but I'll show you. This is to clarify the anatomy and also create some space for us to work with. So you see the mucosa, and now this is the septum here. And we're gonna start cutting. We're gonna start cutting some muscle now. Sorry, go ahead.
The general cutting is up to 2 centimeters or maybe more.
Cutting of what?
The cutting of the diverticulum in general.
So if it depends on the size of the diverticulum, right? So if the diverticulum is 7 centimeters, then I have to do a 7 centimeter cut. Close. So it really has to do with the size of the diverticulum. So let's just create now more space on the diverticular side.
In your practice, what's the rate of redo procedure?
With the Z-POM, it's very low, less than 5%. So let's clean this knife, please, and we'll go back to cutting.
Maybe you expect less with this combined technique.
Yeah, I think the main advantage of this combined technique is for large diverticula. So here's let's just pause here a minute and show you this here. So the muscle in most Zenkers tends to split. So this is the muscle on the esophageal side, and this is the muscle on the diverticular side. And once now we start doing the myotomy, you're gonna see splitting in active time. And once you see the splitting, you'll be able to tell the muscle on the diverticular side. And you start that myotomy on the diverticular side. Once you finish that myotomy, it means you're at the bottom of the diverticulum. And that should guide the myotomy on the esophageal side. I don't know if it's clear now or not, but I'll show you in a minute. So we're gonna start cutting more septum here. Open, Bayumi. Open. Good. So turn it, please, to make it perpendicular to the muscle. Turn.
Dr. Moin, please.
Yep.
What's the contraindication according to the size or to the depth of the diverticulum? When is the contraindication to do this procedure?
Really none. Close. There is, as long as you can delineate anatomy, we've done it in post-surgical patients with very small diverticula, very large diverticula, so there is no contraindication. Okay, so here you go. So now, you see this muscle here? Let me just put some water so that you guys can see it better. So this is the muscle on the esophageal side. So we don't have to really create a big tunnel here. We don't have to tunnel. We can just cut this muscle. So we're going to start cutting here, open. And knowing that there is muscle that's separated from this on the other side. Close.
Dr. Moin?
Yes, go ahead, please.
How we can decide, how we can differentiate, can you tell us how we can differentiate if this muscle or this is submucosa?
Yeah.
What's the criteria for differentiating?
Open.
So that we can know what we are working.
So you know when you stain blue, everything that stains blue is submucosa, and that's why we inject the blue color to basically delineate the muscle better. And the muscle is this white structure here that looks, all muscle will look like this. Close. So once you start working in the submucosal space, you'll get used to the colors. But one main reason we inject the blue dye is to, this is by the way not still a big issue with this, huh? It's not cutting well. So this should be like boom, 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 cutting like magic. Open. And, okay, close.
Try.
Let's see. Much better. What did you do?
Reduces.
Okay,
Reduces
so less coag effect. Okay, so now we're gonna come on this. So this is this is the myotomy on the esophageal side. So now we're gonna come back and ensure no muscle remains on this side, diverticular side. And we see that there is muscle here, right? And that's normal because we haven't really done a complete myotomy. And note that with these big diverticula, can we cut down the volume here because I'm hearing echo? With the big diverticula, we have food stasis on the diverticular side, so it causes basically inflammation and submucosal fibrosis. So you see a muscle adherent to the mucosa in large diverticula. Not an issue with this technique because we're going to get rid of the mucosa anyways. So not a big deal. Open. Nice. Close. So we want to make sure we're not catching the mucosa on the opposite side, but
the coagulation mode is always cutting for this procedure.
So this is endocut Q, which means this is a current that goes coag cut or cut coag. So this is a blended current. So so we see here still, you guys see this muscle here that's adherent to the mucosa. So we're gonna cut this a little bit more, and then we'll trim the submucosa a little bit here, and then we are done. So and you'll appreciate it better once we're done here. Open. So for the sake of the live, for the other rooms, if you guys considering switching, and so this we just need about 7 minutes, and this will be done. Okay. No, I'm taking my time just to guide you guys. No problem. I do this all the time. So
what's the median stay in the hospital?
So the next day we get an esophagram, and then if that's good, they go home. Okay.
With a soft diet for many days, no? Liquid, starting with liquid and then soft diet during 1 or 2 weeks?
We start liquid, and if that's good, then you go for a soft diet for a week and then advance as tolerated. But this is typically exactly it. So so you guys see here, we're at the bottom of the diverticulum. We don't see any muscle here. This is all submucosal fibers. And we see that the muscle here, what we cut on the esophageal side is about a centimeter and a half deeper. And that's on purpose. So we always extend it by a little bit. So now what we're gonna do, we're gonna extend this mucosal cut to be below the muscle here. Otherwise, we're creating a pocket for food to accumulate.
Yes.
So this mucosa, you have to cut until you are below the myotomy site.
Okay.
And once we accomplish that, the procedure is done. And so there is no muscle, there is no mucosa, and no need to clip. Open. Close. So I have now experience with 30 cases this way that we call Z-Poem, and hopefully the manuscript will be published soon. So we did the first live case at my course 2 weeks ago. We never talked about it before because we wanted to ensure the safety of this approach before we preach it. But in my opinion, the advantage of this, you're still using this Z-Poem to ensure a complete myotomy. And then you're cutting the entire mucosa to avoid any redundant mucosa. And then you're avoiding the most difficult part of the procedure, which is mucosal closure. Especially in big diverticula when you cut the mucosa. when we do the mucosal flap incision, we call it MFI. You need like 12 to 15 clips. If you guys remember, we did that last year. And so here I'm going to just trim these a little bit. So let's clean the knife. I'm going to trim these a little bit here, and then we are done.
And it is less expensive.
Yeah, I mean, you know.
So you don't have an idea about the durability?
Durability?
Yes, for the combined technique.
So the combined technique, it's either going to be similar durability to a regular Z-poem or more, because we're doing exactly what we do with Z-poem. The only thing we don't do is clip. We're doing an additional thing is mucosal incision, the complete mucosal incision. So we're hoping at least durability is as good, if not better. And so we're making the procedures easy to do, more scalable, because you don't have to close. But it's okay. He wants it shirky. So we're not going to open it now, okay? We'll just use the tip of it to trim a little bit here. Okay, you know what? Just take this out. Let me clean the lens. Can't see anything here. Take the knife out, please. Okay. Water. Strictly on. All right.
If any question, please, from the audience.
So we're gonna just finish it now with some trimming here in the middle. And then we are good to go. Okay, so any comments? What do you guys think? Do you like it?
Did you?
Yes.
You want to perform a randomized control study, with the poem, yes?
Yeah, so I think usually we like to publish initial retrospective, understand the safety, let other people try it, refine it, and then do a randomized trial. Yes, sure. So we're definitely heading that way, and here you see just a little bit of trimming here. So here I'm just using the tip of the knife, and also we're using one knife. We're not so the cost is really good. Okay, so this is done here, and this is the muscle, and the mucosa is under the muscle. So I think here this is completed, and you see here there is nothing left here.
Very plain.
Yeah.
Okay. Yes. Perfect.
Thank you, Dr. Ma'in.
Can you please raise the volume a little bit so that I can hear them? Sorry, I can't hear you. And here's the scope.
Beautiful.
Thank you.
I'm telling you that most of us in Lebanon, we don't, as a gastroenterologist, we don't dare to do this procedure as it may have a high risk of perforation. So what's the learning curve for us so that we be confident with it?
Yeah, I think this is a very good question. So before we do Z-poem, you have to get comfortable with esophageal poem, which is easier and we have longer experience with. Once you're experienced with esophageal poem, then you move to Zenker's. It becomes just a matter of time because it is the same approach: incision, tunneling, and myotomy. And with Zenker's, the anatomy is different, so you have to understand a little bit of the principles. But you see, the principles are not that difficult. So if you watch a couple of these procedures, after you complete your learning curve with the esophageal poem, you should be able to do it. And just to let you know, here, Dr. Humani, at this hospital, he started doing poem. He's doing poem. And I think it's just a matter of time. After he gains a little bit more experience with the esophagus, he will move to Zenker's.
Do we need antibiotics for this procedure?
Yeah, same as with poem. We give we give antibiotics before we start, and we give antibiotics for 3 days. So we typically send the patients home on Augmentin, BID, for 3 days. That's it.
Thank you, Dr. Moeen.
Okay, take care, bye-bye.
Excellent job.
Thank you.
Okay. So, so far we
Yes, we
couldn't
hear you.
cannulate, and we reviewed. Are we live? Yeah. And we reviewed
Can we
the
see the
previous
endoscopic?
images.
Can we see the endoscopic image?
Yeah. Please show the endoscopy image. Do you have it?
Yes.
So, and
Yes, yes.
So according to the previous video recording of the cannulation, the orifice was somewhere here and not at this bulging part. And therefore, the needle knife sphincterotomy was done from here, from the orifice, and now I tried everything to identify orifice, as you have seen, but we couldn't see an orifice. I carefully advanced the wire and tried to probe with the wire. Impossible. We couldn't approach a duct. And then I repeated the sphincterotomy to get a little bit deeper because it's a bulge. So hopefully we can come closer to the orifice, but we still were not able to cannulate. We cannot see any formation or layer which looks like a duct. Probably are still in the submucosa.
If the cannulation fails, what will be the next step?
The next step is an EOS-guided approach with pancreatic cogastroscopy to advance the wire from the antegrade approach and then to do an antegrade rendezvous procedure. So
that's why I asked the question in the beginning.
Yeah, but only in case of failure of ESCP, huh? So we try again from here. No.
Hello. So can we know
Resistance, huh?
is every cases with division that cause pancreatitis should undergo minor papilla sphincterotomy?
Can you increase the volume? We cannot hear you, unfortunately.
Does every case with pancreatitis secondary to division need minor papilla sphincterotomy?
Well, this is a good question. Needle knife again. Ah, yeah, okay. This is a good question. There is, so far, as far as I know, an ongoing randomized controlled trial. But according to the literature, mainly retrospective studies, about 2/3 of the patients benefit from the minor sphincterotomy, minor papilla sphincterotomy. So I go a little bit, I would like to open up the roof here to have a better view of the deeper layers. So as we have heard, the orifice was here, so I prefer to go upwards, not downwards. And I use endocut 224. So then needle in, and I try to get the tissue aside to have a better view of the deeper layers here. Hopefully we see a structure which could be the pancreatic duct. No. Okay.
Sorry, When you decide to stop trying cannulation and go to next step at time, you know how many time? Half an hour, 1 hour, or we don't need the time?
So cannulation maybe as we did after 15 minutes, and with pre-cut, so we cannot go much deeper. It doesn't make sense. But maybe in 10 minutes or so we should stop. And then maybe in the next session to do an EOS-guided approach. I always thought the papilla would be lower here, but the videos showed that the cannulation was done from this side, open. No, the knife. We open up from here a little bit. So you have to have a very good control of the knife. Pre-cut of the minor papilla is challenging, of course, especially after a pre-cut. We don't know so exactly where to cut because we can no longer identify the orifice. A knife in. Okay, now
What's the size of the pre-cut here?
The length? Yeah, maybe 1.5
centimeters. Yes.
More than a centimeter. Huh? But as you can see, we do it very carefully. You don't see any edema. So because we didn't inject. No?
So, in case of failed cannulation, is there high risk of acute pancreatitis?
There is a risk, maybe not high, but there is a risk. The patient got indomethacin before. Okay. Okay, we are in.
What about perforation risk?
We're in.
Yes.
Thank you. Stop. You see, yeah, it's already in the tail. So, and this is, can you see on fluoroscopy that we're in the tail?
Yes, can we have a moving image?
Yeah. So you can believe me that the direction of the wire is in the direction of the pancreatic tail. So I don't inject at all because we know the anatomy from the MRCP, so this would increase the risk of pancreatitis. When the guide wire is not smoothly passing in the direction, then you should inject a little bit of contrast to assure that you are not in a side branch and to overcome an angulation or so. But here we are in the I don't inject, and now now it's even more important. So thank you very much. He should get the applause. Huh? Yeah. So, and now we change against the sphincterotome. And as you can see, this is
we can see the fluoroscopic image.
Okay, perfect. So we don't need fluoroscopy. We just watch the wire that it changed, that it stays in this position, and we change to a sphincterotome to proceed to sphincterotomy, and I will show you how this will be done in pancreatic divisum. So it was good that we extended the cut again. Push. Is it a short wire? No.
No, no, it's he was in the way.
Yeah, of course we are very careful. I don't want to lose access. And there's still peristalsis here. And I don't want to use fluoroscopy to reduce the X-ray exposure. Okay, I have the wire. So stay 4 minutes with us. So we already we switch this setting to 211. 211 cutting. Let me see. Give me the machine. No. Give me the access to the machine. So 211 or even 111. 111. So, okay. Now make the wire wet, sphincterotome, any kind of sphincterotome.
Dash, please.
Dash is fine.
Dash 25. Is okay?
Yes. So I use the Irby Vio 3 and I had the cutting interval on 4. That means it's an alternation between cutting, coagulation. 4 is cut, cut, cut. You hear the beep, and in between you have the coagulation. And the intensity of the coagulation depends on the level of the effect. The higher the effect, the more coagulation. And now I use 111, and as you will see, it will cut very quickly. Cut, 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 short cutting intervals.
They have in 21. I will get you the 25 because 21 will not go. This
Yeah, then give me a regular, any kind of sphincterotome. So that means it's more or less pure cutting. Cut, 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 to minimize the risk of trauma, thermal injury of the pancreatic orifice. But it seems to be a little bit difficult to get the sphincterotome.
Can you comment? Hello. Can you comment to us about stenting here?
Yes, of course. Of course. There is no stenosis. So after sphincterotomy, there should be no stenosis anymore, and therefore we need just a prophylactic pancreatic stent. 5 centimeter. Usually we use just 5 French, 5 centimeter. But only for we can cut off. We can finally cut off also the proximal flanges, and then it's very likely that it will pass spontaneously within a couple of days. So like you do use a prophylactic pancreatic stent in case of manipulation at the minor papilla, a major papilla. Because
what
when
about the future?
Pardon me?
About the future of this case. The future of this case, when you put the stent.
Oh, is it so difficult?
If you have to change it or to do something.
The future is that he has a probability, as I said, so can you just pull on the wire to keep the wire straight? The probability that he benefits is at least, please concentrate now on the wire. Is about 70%, and this patient suffered a lot, so recurrent attacks of pancreatitis. Pull, 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 pull. We should there. No. We as far in as you can see, we are too far inside because we don't. This is also important. Of course, we don't want to lose the wire, but the wire should be not too deep in the pancreatic duct. Okay, now the sphincterotome is inside. There is some resistance. Okay, but now we are inside, and now we bend the wire a little bit, and as you can see, we have now, when you see the brownish ring, we have only 1/3 of the cutting wire inside. So tension on the wire, and as I said, the direction of the Santorini duct is towards 10 o'clock. So therefore we cut in this way, and I maneuver the shaft of the endoscope. I don't touch the catheter. So this is like the handle of a grip of a scalpel. So, and therefore, as you can see, it cuts quite fast. Very little, and you can already see the pancreatic juice coming. You see the whitish calcified juice. And of course, in a second, you will ask, how far can we cut? This, of course, depends on the size of the minor papilla, and you can now already see the duct. Yeah, I show you. You can already see the ductal wall. That means we have now a very easy access to the Santorini, and it doesn't make sense to cut much more, because then we cut into the duct, maybe a little bit more. And just to show you now, only the blue ring is inside. Bend a little bit. 1, 1, 1, very fast cut. So if you have the cutting interval on 4 or 5, then it's cut, cut, we have too much coagulation. So this is enough. So yeah, release. So we get the pancreatic stent ready. Now we have a nice opening. Look here. Okay. So yeah, usually only, you don't have 5 French, 7 French. Just cut the proximal flanges, cut them off. Yeah. Then he has 5 centimeter, and you can cut the proximal flanges off. It's just a prophylactic. We don't have to bridge a stenosis, because we cut this one. Yes, yes. Push, push, push. So the patient will be very happy, because he suffers a lot, as we can imagine with it. Okay, okay. So we move to another room, but it's very likely that we will succeed in placing of the stent. And thank you.
Sure.
Thank you. Thank you.
It's easiest.
Hello. Our third and last case in the LIVE2 is a 67 years old patient with a past medical history of hypertension. He has a right colonic LST G-type polyp of 5 centimeter, Paris 1S, 2A, and NICE 3. Piecemeal EMR was failed in another institution, failed to resect the whole lesion because due to technical difficulties and couldn't lift the lesion. So decision was made to do endoscopic submucosal dissection, ESD, which will be done by Dr. Pradeep and Dr. Asma Al-Kandari.
Hi again. We want to discuss this case.
Hello.
This is a gentleman who has been through a colonoscopy before and a previous resection of the partial right hemicolectomy, and because of his poor bowel prep, difficult access, we managed to reach the site of the previous resection, previous attempt of resection. Because of difficult access, there was a recurrence, and all of us, we know that SMSA score, if we calculate it carefully, this gives us a clue about the risk of complication and recurrence after resection. And while we are going through, we have seen a lot of polyps, but this lesion, which is the site of previous resection, we can understand the recurrence because it's really a difficult access. And what you think, Pradeep? What's your strategy? What you're gonna do now?
Well, it's a very challenging situation. He's had previous right hemi. He's had an EMR attempted on this large LST.
And left side diverticulosis as well.
Yeah, and they failed because the scope position was unstable. And during colonoscopy, we have found that he has a very long mesentery. So when patients have very long mesentery, as you push the scope, it just loops and loops and you run out of the scope. And then somehow you can push and get to the scope, but you'll always be very unstable. So once we understood that, we decided to put our CO2 off and went completely underwater. But then the challenge was poor bowel prep. So it's taken a long time to get here. Now we find a polyp which is scarred at multiple places. So you see this central scarring there? That's the worst bit of the scarring. Then you go further in, and there again, it's all tethered inside there. So that's scarred there. I think on the side, maybe there, it's not scarred, this, and then right down here it comes. So it's a very irregular shape. My thoughts are we could attempt EMR again. We could do ESD.
Underwater?
Or we do underwater. Now for EMR and ESD, I'll have to inflate the colon. As soon as we inflate, the scope becomes very unstable. So we might face the same challenge. So underwater might be a good option here. So what I want to do is first just show you, hang on a second. Let me show you, we don't need CAD-I, this is quite big. Let me just show yeah. Okay. So if we look with BLI, we can see the extent of it. You can see that we've done some marking. In polyps like this, it's very important to mark so that we know our boundaries. You can see otherwise, it's very easy to miss subtle areas. So once the marking is done, what I would suggest is that we'll probably try a test injection on the sides to see if we can get those sides. And then the scarred bit, which is left behind, we'll try to do that underwater. And that probably injection will make it worse. So why don't we start with the injection? So if I can have an injection, yeah, we can go back to white light, please. So I think what is this injecting solution you've given me? LIVE2. So we're going to use LIVE2. As you know, it is quite viscous. The only thing is it doesn't have adrenaline. And some people prefer having adrenaline into their solution, some don't. I personally think it doesn't make much of difference, but when you use adrenaline, intra-procedure bleed rate is definitely less.
And give you a little bit of satisfaction?
Yeah, it looks less bloody, it's pale, so it's all clean. Whereas without that, you get a little bit more intra-procedure bleed, and also you see a lot more vessels. So our needle should come out any time now. Okay. So let's have a look. I think if we target on the right side and try to take this off, then we go try to take this off and at the top, and then we'll be left with this scarred bit in the middle, and we'll try to do that underwater without injection. So let's see how it lifts first.
Can you explain the strategy of injection to get a good lift with the dynamic elevation?
So first is some people just push the needle in, inject, and then you pull back till you find the plane. Some people get the needle out and then you push it in there, and then you start injecting, keep pushing in till you find the submucosal plane, and when you get a lift, you stop. I prefer to push and pull back. So needle out, please. So I'll go into this area here, inject. I'm not in. Yeah, okay.
We're not expecting a good lift here because of fibrosis.
No lift at all. Can you flush that, please? Flush, flush, flush. Asma, do you have the water jet?
Yeah.
Okay, let's stop. Let's go back in there. Okay, needle out. Inject. It
What
won't go
will be
in
the
at all.
amount of the injected
It's
solution?
very scarred. Okay, yeah, yeah. So I'm pulling it to me now as we got a little bit of lift. Yeah. Okay, 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 okay. Carry on, carry on. Stop, stop. Okay, that's good. And let's try to get this bit here. The problem is the snare in the middle will slip because that is where it is scarred. Let's get needle out, please.
There are some strategy where you take the whole things and the fibrotic area by Avesco, FTRD.
Yeah.
But I think even Avesco here is very challenging because of the axis and position.
I won't lift here.
What do you think, Pradeep?
My gut instinct is that we might have to do the whole thing underwater. Where is Rad? Not Rad. Where is Zahar? Zahar here?
No, here.
No?
Hello? Do you hear us?
Can we get a 12 millimeter snare, or what is the, after 10, what size do you have? 15?
Why don't try to inject it here?
Needle out. Inject.
Do you hear
so
us?
Zahar, we're thinking about going underwater, which does risk perforation. So if we have the right clip, stop, 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 thank you. So if we, any clip, Boston, Microtech, yeah, so my feeling is I think injection is not going to work. So we'll stay underwater, take a big bite, and take this scarred bit off. Yeah. If we have a perforation, we'll just put the clips and close it. You happy with that? As you are the host, you're God. I need your permission. Yeah. I could take the water out once we got the snare polyp in the snare, so that it doesn't leak out. Yeah. But I think without the lift, any other technique is just destined to fail or cause perforation. Yeah. Our cold will not cut purely because it's scarred. So if we change that forced coagulation back to 2, please. Can I have the snare?
ما عم يسمعونا بالصالة. شو بنعمل إيفنترا؟
Can I see your snare? So generally when we do underwater, we like to use a very stiff snare.
ما عم يسمعونا.
So this is not so stiff, but I don't think we have another snare. So we'll go with this. I don't think we have captivator. So, okay, let me see.
Boston.
Do we have?
Boston.
So I think the stiffer the snare, the better it is. So the thinner, so monofilament stiff snare is the best for doing anything underwater because it reduces the risk of catching extra bit of tissue in it. This is a very floppy snare. While they try to find me another snare, I'll see what it does.
Professor Bandari, do you hear us?
Oh, sorry, did you ask us something?
Yes, I asked you if you hear us in order to ask a question.
Yeah. We can just about hear you. Ashma, my hearing is poor. Can you try to hear what they're saying?
Yeah.
So when to decide to do in case of LST in the right side or in the rectal segment? I don't know if there is a difference to choose between ESD or EMR in a primary lesion which was not resected before.
Yeah, we
what
do.
are your criteria to choose to go for ESD rather than EMR?
Yeah, there are many criteria to do ESD rather AMR. First of all, the bit pattern. If you're suspicious of like some invasion, like 2C or 3, you have to go for ESD. In like any lesion in colitis, like any lesion in colitis is better to do ESD rather than EMR.
This is too big.
Lesion.
Big, small.
Like.
Big, small. 10.
Pradeep, what you?
Sorry, what was the question?
The ESD, when you decide to do ESD rather than EMR. I told them that...
yeah, if you suspect cancer...
Cancer.
Too big, small? No. Or scarred lesion in colitic bowel, they will not come by EMR. But when you have severe scarring and tethering like this, then ESD is also very, very high risk. Do you have a 10?
Okay. Can I have a question? For this lesion, whatever you choose, if you choose EST, risk for perforation. If you choose EMR, risk for recurrence, maybe.
Is this 10 millimeter?
Not complete resection.
No
what
10?
do you think for full cut resection or refer to surgery?
Okay, so we will shift to a new case. He is a 64 years old male patient known to have hypertension, diabetes, and dyslipidemia. He was referred to us for POEM because he was diagnosed to have type 2 achalasia. So when we did the gastroscopy, it was difficult to bypass the cardia, and we found a gastric submucosal lesion just below the cardia. So after creating the tunnel starting at 32 centimeters, the procedure was stopped because of the marked fibrosis at 40 centimeters at the level of the stenosis. So as you are seeing in the video. So calling into question the diagnosis of achalasia. So the mucosal entry was closed by clips, and then we placed a partially covered metallic stent 10 centimeter, 26 millimeter. After taking a thorough history from the patient, he mentioned the ingestion of a caustic substance when he was 2 years old. 10 days ago, we inserted a fully covered metallic stent 12 centimeter, 26 millimeter, inside the previously placed stent. So the plan today is to extract both stents and do EUS for the cardiac submucosal lesion with possible FNB. Will be done by Dr. Gabriel Rahme and Dr. Hussein Okasha.
Hello everybody. I'm very happy to be here in Lebanon. Happy and proud to be here, and I will share with you this case, and we will perform together the case. I will remove the stents, and with pleasure I will give you the part which is the EOS part. It is quite an unusual case. There is many things. First, there is a stenosis and probably dysphagia in this patient. And the first hypothesis was some like achalasia-like. And there is another point, which is the submucosal tumor. This is the second part of the exam. Then we are in the esophagus at the distal part. It's 35 centimeters from dental arch, and you can see here the proximal part of the metallic covered stent, and of course we can pass through the stent. And in the history, I think that there is two stents, one incarcerate stent. It was a partially covered stent, and this stent, which is a complete, fully covered stent, to help to remove the first one. I will use this forceps. Perhaps I recommend to use strong forceps to remove, for example, foreign body, something like that. And the strategy is to grasp this part. We can see at 11 o'clock to grasp the line, to pull back into the operating channel. Okay, I will just wash my... Okay, you can open. I try to grasp. Yes, close. Okay, I'm not sure. Okay, you can open again. I will try to better grasp. Just here you can see the wire. Okay, just here. Yes, close. Okay, I'm not sure. Oh, okay. I think the objective is to pull back the line and to close, as you can see at just here, to close the proximal part. We can, okay, it release, open. Yes, open. Because sometimes it's quite fragile. Close. And because I think we broke the wire, open again. Yes. Okay, close. I do some light movement just to disconnect this proximal part to the mucosa, because of course it's remained sometimes open. Please again. Okay, we will try to grasp the wire here. Close. And I pull back again. Okay. Now I block the forceps with my left hand. I just make some rotation like that. I pull back. And I hope that we have the stent. We have it. I give you the stent. Okay, then we can say that this is the first, the second stent, and we will see now the first, which was the problem, because the first we cannot remove it because it was incarcerated in the mucosa. It's quite usual when you use partial covered stents, and sometimes it's after 2 weeks or 3 weeks. It's very quick, and you cannot remove the stent. Okay, this is the other one. We can see. We will. Okay. We can see here the mucosa through the stents. Oh, it's quite challenging, but we will try. Please, I will take the forceps again. Ça va être de la boucherie. What do you think?
There is tissue growth at the proximal aspect of the stent.
Exact.
Make it very challenging, but we hope that.
I think it will be challenging to again. Yes, but we have to try. We will take probably more time than expected. We will see if the second stent worked well. I'm not sure. We can just try to move it like that, just to see. Ah, okay. Okay, not so easy, I think. Okay, open, please. Yes. We will do the same thing. And I hope the line will not break. Close. Okay. And now I try to close. Okay, the other possibility. Okay, open. Close. I think, yes, close, please. Oh, sir, thank you. Ah, why not? Look. You can see that the proximal part is quite okay. There is no. Okay, I pull back the forceps and I go to see how is the situation. Okay, it's a difficult situation. We know that. Perhaps we can think about another strategy, which is the possibility to grasp the distal part.
Yes.
I don't know if in this stent there is a line also. There is no line in the. Sometimes you have the chance to have. You have the chance to have one first line, proximal line, and one distal line, and yet you can just grasp the distal line and pull back like a sock,
yes,
you know,
like a sock,
and you. Okay, then some expert in the LGNs ask me if I can push the stent into the stomach, inside the stomach. The problem, as you can see, is there is an incarceration here. And of course, I would like to push it, but it's, the stent is fixed here. Okay. Open, yes. I try to grasp the stent, close. And even if I can not push, open. You see the ingrowth part of the mucosa. It's quite 1 centimeter. Close, please. 1 centimeter. I'm not sure that we can detach it now. Okay. Okay, then.
Hello.
Yes.
Do you think that we should have inserted a fully covered metallic stent from the beginning in this case would be better for the patient?
You mean to put another one, another?
For the first time.
For the first time, yes.
But the migration rate is very.
Yes, the risk, you know, is the migration in this kind of benign structures. Then I think we can discuss, of course.
Gabriel, do you think covered one is migrating?
Yes, I think the first one is there was a migration of the stent, and the cover to cover this part. Yes, I think we can put a fully covered. we can discuss the shape of the stent. There are some stent with like a reinforcement of the body. I don't know what kind of stent we have here, but we can see and discuss what kind of stent we can put. Yes.
Do you think there is any role for APC in this case?
Do you hear me? No.
Oh, sorry, I can hear you very well.
Any role for APC, argon?
Sorry, can I ask something? Sorry? Do you hear me?
APC argon, it works not so well. In my experience, it's not was so well. And the best strategy, you can see here the delaceration. Yes, the best strategy is to put another stent.
We have a question from the audience. What do you think for grasp stent anal side to pull oral side?
To place another stent?
No. You hold the stent
yes.
from the still side.
Yes.
Yes.
But
and take and pull. Yes.
Yes, exactly.
No problem. We work.
Yes, we was discussing this case just before, and in this case, to pull back the stent, you have a line to close, you know. But we can, we can of course try perhaps to pull back like that, open.
I think it works.
Open. Close. No. Close. You know.
Yes. Go. Don't worry. Go.
Okay. Yes. You see? Yeah. Perhaps there is a possibility.
Yes, very good.
Yes, I can. We can see that we can pull back now, and just now we can retrieve the stent. Thank you. Now we will see the situation of the esophagus. Yeah. But we are very confident, no? Because after you have to use an echo endoscope.
Yeah. But upper endoscopy first to know, to see.
Can I have some water, please, just to wash? Thank you. Okay. We can just make some palpation here of the chest. There is no emphysema. First good point, perhaps? Sure. No, never. We have to check now. Okay. Then I just said that at the beginning that there was a stenosis, and this patient had the beginning of like a poem.
Endoscopic image.
You cannot see the endoscopic image?
No.
Oh, sorry. Probably they will work on it. Sorry about that.
No problem.
Okay. Then I am in the esophagus now. There is, of course, bleeding. I use a washing pump just to see the delaceration and to check if there is some perforation or something like that. Okay, this is, we are at 30 millimeter and okay, there is just bleeding, it's okay. Okay, this is the location. Then there was a history of GERD reflux in this patient. We guessed that probably the stenosis was post-peptic esophagitis. It was a caustic injection. Okay. In the history, there was a caustic injection during the childhood. Okay, perfect.
Can we see the fundus? Can we see the fundus?
Oh, yes, of course, we can see the fundus. Just to say that I think that there is no complication, okay?
Yes.
I hope.
We can move to another room.
Yes, I just want to see you the submucosal tumor, of course. Okay, this is the submucosal tumor. The cardia, just below the cardia. Typical aspect. And I think, yes, now we can switch, of course.
But I think it may be a granulation tissue because it was not there during insertion of the first stent.
Okay, perfect.
Doctor,
then,
okay.
Okay, thank you. Thank you, Zaire. Thank you. It was there.
It was there before insertion of that. Then it will be a
the submucosal tumor was there at the beginning, just before the first stent.
But this is, of course, not the cause of stricture, because submucosal tumor never produces stricture. It may be the corrosive or the reflux. But we should exclude.
But because I have the entrance of the tunnel.
Corrosive stricture is a precancerous lesion. It may develop adenocarcinoma.
Thank you.
Yeah. Oh, are we? Okay. Welcome back, guys. So what are we doing so far? If you flush there to show. Yeah. Flush. Keep going. So what we're doing is a combination of different techniques of we snare resected underwater the central scarred bit. This is very scarred, which flush, which we cannot resect without cutting around it. So now we're using a knife to create an incision all the way around it so that we can fit our snare back into it. And you see in the middle, flush there. Yeah, keep flushing. This is severely scarred here, so no snare will engage in this. So we have to just go under it here, like you can see, and create a bit of a groove. Flush. Okay, so run out of water.
Okay,
change the water.
Yeah.
So I'll inflate and show you what we've done so far while we go underwater again. So what we're doing is this central bit came off underwater. Then we're trying to take this distal bit, but it won't come in the snare despite multiple attempts. So we're using a knife to create this divot. You see that? This will allow me to engage my snare into this area, and then we'll be able to cut it again with the snare. And so it is not all about ESD or EMR or underwater. It is all about what is the best way of safely resecting this polyp.
Professor Bandario, what do you think for full thickness?
Asma, can you hear?
Or before surgery?
Full thickness.
Because if you
well, FTRD would have been a very good indication. However, even getting this scope here took us 2 hours. So if we had FTRD attached to the endoscope, it will be an absolute nightmare to get here because this patient has a long mesentery. So no matter what you do, he loops in a big way. So yes, conceptually, this is a very good indication. But also the other challenge is
The 2
it's
centimeter.
about 3 to 4 centimeter in size, and FTRD works best for about 15 millimeter lesion. Beyond that, FTRD doesn't work. So I'll try to make a groove around here. Once we have a groove here, I think our snare will begin to engage again. So you see this challenge partly now because of the scarring, that area has become very stiff and doesn't allow my scope to stay stable around here. As in contrast to ESD, when we do this kind of technique, we can cut through the adenoma, it's not a problem. Flush, I can't see. Flush, carry on flushing, please. Flush. Yeah, I need to see. Yeah, that's better, carry on. So this is very delicate, very high risk, but we don't have any other choice here. But we can't rush this. Yeah, flush, excellent. Carry on. Okay, so we might have a nice divot in which we can flush that. Flush. Yeah, I think we should be able to catch this in our snare now. I just need a cut at the top end. You see that? If I can bring that backwards from the top, our snare will sit in nicely into this. So here you will see I will cut through the adenomatous tissue. Can I inject, please? Knife back. I inject. That's the advantage of having knives which allow you injection. Okay. And knife back. Yeah, inject. I'm trying to bring the injection forward by tilting my scope. Yeah, inject, stop. Can you flush to see what's flush?
Professor Bandari? Okay. If you had small caliber cap, maybe big chance for you. Very small caliber cap, like chest hood, because severe fibrosis is very difficult to get submucosal space.
Yeah. Would you repeat the question again, please?
No question, only some idea. If you had small caliber cap, very small caliber, like chest hood, maybe easy and big chance for you because the get submucosa very difficult.
Is a small caliber what? I didn't hear it properly.
Very small caliber cap, like chest hood.
We're using cap hood. We're using the hood. We're using the Fuji hood.
Chest hood, yes. No, smaller than.
Oh, this is the smallest one that we have.
Yes. The name chest hood.
Is another company. I don't know. I didn't hear about this. What's the name of the cap? Can you repeat it again?
Chest hood.
Chest hood? Have you heard any cap called?
Top corporation from Japan.
Is it from Japan?
Top. Is it top?
It's a cap, but with a small diameter.
Hit flush. Yeah. Okay, yeah. So you can see, guys, we have isolated this patch. I'm just going to put a snare and take it off while you go to another room. You can come back again. Yeah? Okay, give me the snare now.
It's a gist. You think it's from the muscle. It's from the muscle.
From the muscle. If you count from here, it will be from the muscle. Then now we are just below the cardia. It is about 41 centimeter from the dental arch. And here we can nicely see the mass. Can you freeze that, please? Please freeze. We can measure it. This is the polypoid lesion. And the most important task is to determine the layer of origin. This is about 26 by 19, about 2 centimeter by 2.5 centimeter. And I should apply Doppler. Please, can you apply Doppler, please? Apply Doppler here. Yes, here. Yes, there is some color flow Doppler inside. But the most important task is to determine the layer of origin. We count it by 2 ways. Freeze, please. Freeze. Yes, freeze. We count it by 2 ways. The first one, this is the lumen of the stomach, and this is fluid inside the stomach. And so this is the mass. When we count the layer, the first hyperechoic layer is the mucosa. The second hypoechoic layer is the muscularis mucosa. And the third layer, hyperechoic layer, is the submucosa. And so the mass, and this is the mass, so it is most probably originating from the muscularis propria, which is the third layer. We all know the layers of the GI from the esophagus to the anal canal. It is formed of 5 layers, 3 hyperechoic layers, and in between 2 hypoechoic muscular layers. So we count again: mucosa, muscularis mucosa, submucosa, and here this is the muscularis propria. So most probably it is originating from the 4th layer, stromal cell tumor, and the differential diagnosis here will be GIST, gastrointestinal stromal cell tumor, versus leiomyoma. I am more with GIST because GIST tends to be more hypervascular. You can apply Doppler. Yes. Okay, there is a vessel inside. So it may be this or that. It is a stromal cell tumor originating from the muscular layer, the 4th layer, which is the muscularis propria layer. And it is measuring 2 by 2.5 centimeter. So it may be gastrointestinal stromal cell tumor or a leiomyoma.
Yes.
Here, schwannoma is very rare because schwannoma mostly occur in the esophagus. And here, this is just at the cardia. But it should be put in the differential diagnosis. Here, where we will inject water, it will help us very much, but I think it is very clear without injection of water.
Exact.
Okay, now, now, 2 minutes.
2 minutes.
Now we will prepare, this is the liver. Now we will prepare for
the punction.
FNB. I tried it from the opposite side. Maybe it become more easy. I turned myself, and I asked the help of Dr. Rahmi. Can you fix? Can you fix?
Of course.
Please?
Yes.
Can you fix? Okay, like that.
Yes.
And here, I will introduce the needle. This is 22 GFNB needle, acquired needle from Boston Scientific. Here I prefer FNB because we may do immune staining like 117 and DOG1 for GIST and dysmine mucin actin for leiomyoma. Then we'll introduce the needle out. Yes, it is now well seen.
Yes.
And I should apply Doppler first to determine any intervening vessels, no intervening vessel. I will ask Dr. Rahmi, thanks for his great assistance.
Thank you.
To fix the scope. And then I will remove.
Yes,
I remove and start to proceed the needle. And a single.
Excellent.
I am now in.
We can see the tip of the needle
here
inside
as the lesion.
The tumor.
Yes, we will remove the stylet slowly, while I am pushing. Yes, now the needle is moving very nicely inside. This is the slow pull technique. The slow pull or low pressure or capillary technique. You have the needle? Yes?
Yes.
You have yes. Only 10 milliliter. Only 10. Half of the syringe. I prefer to do low pressure by half. Yes. Okay. Put it. Withdraw كمان. Yes. Very nice. Thank you. And then we will open. Yes. And I'll do here fanning. Fanning is very important. Fanning is very important. I do fanning by the up and down big wheel. Now I'm doing down, so changing as in my lecture. Fanning is very important and very helpful. I am now moving up and down to and fro movement. At least 20 movements is needed, and up to change the needle track, doing fanning. And here I am moving conveniently inside the mass. Oh, less than 1 minute. Okay. We are now about to finish. Now I'm doing fanning. I pass all over the tumor, taking biopsy from different parts of the lesion, down again and up, and the elevator. Both can change the direction and helping in increasing the adequacy of the specimen. Okay, hoping that we will have a good core. Okay, very nice. Then I withdraw the needle. And when I get the needle out, here it should be at 0 in order not to damage the scope. And here I observe for the needle or the patent tract sign. If there is bleeding, there will be, yes, this is the needle tract sign. You see it very nicely. This is the needle tract sign. This is the vessel seen previously, and this is the needle tract sign. In 99% of the cases, it stops spontaneously. So no matter, no worry. But just keep looking for the patent tract sign. Now it disappeared. Yes, this is the vessel seen before. No, still here. Still here. But after 1 or 2 minutes, expected to be finished. And here we are very safe, because if bleeding occurs, it occurs inside the stomach, because this is a gastric lesion. But the problem in pancreatic lesion and lesions outside the GI tract, there may be a small hematoma in between the GI wall and the mass. Here I think it is decreasing in size gradually, and it will stop finally. Enough or enough? Enough? No
it's
need
a good,
for another one?
yes, good specimen.
Okay. And finally, we look to the lumen of the stomach.
Could you have a gastroscope just to check?
What?
The gastroscope, it's possible to use it again or
No,
not?
no more. No more.
Ah,
bleeding.
perfect. Okay, just to check. On
No
va
more live.
checker. On va
Yes.
checker. J'ai demandé
No
à
more
checker.
live.
The flash, t'inquiète pas.
Yes.
Mais tu sais.
Yes, yes.
Yes.
Thank you.
And
Yeah,
do you
yeah.
perform only one or two function? Yes, yes, but in general. Je fais rarement une ponction. And the pathologist aussi. J'ai
And
pas
here
vu en fait.
there
j'ai
is-
pas-
Yes,
Okay,
thank
no,
you.
no, perfect.
Yes, here the bleeding is not too much. No bleeding, so we can
Yes,
withdraw
yes.
it.
Mark would like to check again. I would just quickly check. Non mais en fait,
Okay,
quand il y a de
now
la
I will go
dilacération,
out.
il y a des lambeaux de muqueuse, hein, et ça c'est ce que j'ai vu. Non, je parle du check. J'ai demandé le gastroscope pour rechecker, mais en fait tu verras pas bien parce que tu as de la dilacération et là. Oui, c'est ce que je vais faire. J'ai bien compris.
Yes.
For you.
Okay.
Question from the audience.
Yes. Please raise your voice. Yes, this is the lesion. Color flow Doppler, CD. Color flow Doppler, CD. No, yes. Now we notice that there is a patent track sign disappeared. Very nice. Okay. What is the question?
No, we did not hear. No.
Yeah.
Please.
And now lunch break.
Okay, lunch break.
زميلاتي زملائي أيها الحضور الكريم
Good morning and bonjour. Good morning, I'm Dr. Ali Farag. Helping me, Dr. Mahmoud Hilal.
Hi everyone, it's a pleasure to be here. Pleasure to be assisted by Dr. Shaima.
Good afternoon, everyone. My name is Vikesh Singh.